I'm very, very pleased to be here today. I've suddenly become a really big fan of conferences, which is a bit of a surprise, I suppose, for some people, and it was for me. But in the last two conferences, I've been changed significantly in my thinking, which either means that I'm highly suggestible or that actually it's a reflection of the fact that this area is so diverse, and we are living in an era where we are really required to respond with creativity. And so if you'd heard me give this talk a few months ago, it would have been quite different. But you're going to see that I've moved a little bit, and I really want to explain a little bit about that before I actually start giving the talk. What I'm going to say is thinking about the use of interpreters, professional interpreters in the health context, and also thinking about how we start to incorporate interpreters who are more informal and ad hoc interpreters into the process. Now, that's a big change for me, and I want to say that many people have worked very, very hard to make sure that there are professional interpreters in health services, and I don't in any way want to erode that fantastically good work. But we are living in a new age. We're living in an era of super diversity, and Christine referred to that in her talk, of people's migration patterns changing enormously, having lots and lots of different nationalities, lots of different languages, and people's migration patterns being quite fragmented. We're also living in an era of austerity. And we have to be realistic and think how we can provide services that are going to be of the best quality possible, but also to be creative about the way we deliver them. So the talk is going to be quite practical. Get ready, because I am going to need a couple of people to volunteer in a minute to just do something at my bidding for just as a kind of a demonstration to bring the whole thing to life. Okay, so the issues. Now, the issues, having said that I'm going to talk about not just professional interpreters, most of this talk is about working with professional and trained interpreters, because they are absolutely essential when you're working in a sensitive or a complex health context. And they are quite different. You know, working in a sensitive context requires a whole different set of skills from the interpreter than working in a context that's just very, very simple. What it means, though, is that practitioners like ourselves have to be thinking much, much more actively about how to work with language difference, as opposed to just being passive receivers of whatever is coming to us. And I'll say a little bit more about that in a minute. And it is a challenge, and it is an extra thing to do, but it's phenomenally interesting. So I really, really hope that at the end of this talk, you'll actually feel enthused to think about language. And again, financial implications are that we have got to do something different. We can't just keep throwing more and more money at the situation. It is important, though, that we are really mindful of situations and that clinicians are assessing and monitoring when a situation requires a level of interpreting which you would expect from a professional, trained and paid interpreter. So there are issues that we need to take into account around safety and risk, and you can probably think of more than the examples I put on the slide for you. And the fact that without having appropriate interpretation, there are potential inaccuracies of diagnosis, and also when family members are used, and I'm now not saying that family members should never be used, but when they are used in complex and sensitive situations, there is the potential for compromise of people's dignity, and also the fact that certainly in mental health, and that's the area that I come from, that in mental health, sometimes the very family members are actually part of the problem that the patient is presenting with. So I want you to just imagine for a moment, and this isn't the bit where I'm going to ask you to do anything that's visible, so it's just imagining for yourselves, that you are an interpreter, and you've been told that you're going to have to interpret in a health situation, and you're aware it's going to be quite a complex and sensitive one. You don't know the ins and outs of it, but that's what you're going to have to do. And I want you to just think for a moment about what are some of the fears and the anxieties that you might have about interpreting in that setting. And because I've only got time for a very short talk, I'm not going to ask you to come back with ideas from the floor, but just compare them with a slide that I prepared earlier about the fears that an interpreter might have about going into a health situation. So some of the fears may be around the jargon. Now, if they've been trained properly, they'll have a very, very good glossary of health terms. But there are still terms that might come up that they're not familiar with. It may be quite a harrowing session. Somebody may be given a diagnosis that's quite a shock for them. And are they going to be overloaded with the emotions? Is there going to be any risk? Is the client potentially going to get very, very angry, for example? What's their role in this clinical relationship? Now, I do a lot of work with people who are mental health clinicians, but I think it's really important to think about the role in the therapeutic relationship, regardless of what the context is, because often interpreters report that they are asked to do things that go well beyond the remit of their role. And they end up taking on responsibilities, they end up being asked to break bad news to people when clinicians and healthcare and social care workers just don't want to do it and want to use the interpreter instead. Other fears may be around a lack of knowledge and context, and this one is more for those of us working in mental health. It can often be around feeling that the clinician isn't competent, because we often do things in mental health which are quite unusual and may look quite uncaring. For example, letting people cry for a while longer than you would in a kind of a social context. So that's the fears that are going on for the interpreter. Now I want you to think for yourself, as a clinician, you've just been told you're going to work with an interpreter for the first time ever. What are the fears that are going through your mind, or the anxieties? And if you haven't got any, you should have. Okay? Because the dynamic is automatically going to change, and it is more complex. So just think for yourselves for a moment, and then I'll show you my slide. Oh, oops, sorry. Right. So one of the fears is going to be, am I being translated accurately? And absolutely right, you should have that fear, because if you could answer that question, you wouldn't need an interpreter. And that's why it can often feel very, very scary to work with an interpreter, because you're handing over a lot of control in terms of the communication and the understanding to them. Also, will there be enough time? That's not the question to ask while you're in the middle of the session. It's something to be thinking about beforehand. And if there's only one message that comes out of this talk, what I really want to say is about taking that control of these sessions, pre-planning, thinking through, and making sure that you've put things in place so that things don't go wrong. We're going to do a brief demonstration that does go wrong, just so that we can think about how easy it is to put things in place beforehand to avoid getting into these tricky situations. Some other fears around the interpreter's level of confidentiality and their reliability. And also, am I going to be able to, as a clinician, establish a rapport with my client? And really important, can I stay in control of the session? And it's such an important one, because control slips like that when you're using an interpreter and when you don't understand the language. And it can happen and you just aren't even aware of it. And then afterwards you think, I don't know quite what happened here. And that's why it's so important to be thinking beforehand about how you can manage that and to stay in control. Because ultimately you have the clinical responsibility of what happens in that room. It's not a question of saying, I didn't really understand. That's not going to be good enough. So it is about thinking about how you manage that control. And finally, the fears of the client. I'm not asking you to think this one through, I'm just showing you. will the interpreter know my family? Now, in some cases, patients will want to bring their own family members, and I'll say something about that in a moment. But when they aren't bringing their own family members, and they're having a professional coming in from outside, they don't want them to know their family. Because if it's a confidential issue, it can be a real area of contention. Will they keep confidentiality? Might they tell other people? Might they judge me because we're from the same community? So I might be okay telling this doctor who's not from my community about my sexual health, but I may feel very, very, very differently about having somebody from my community listening to that. Might we be political enemies? Yes, we speak the same language, but if we're coming from a country that's been torn apart by civil war, we may have been fighting on different sides. And again, will they translate me accurately? Okay, all right. I now want to do a very brief demonstration to kind of bring to light and bring to life the dilemma around working with an interpreter. So I'm going to set up 3 chairs in a kind of an equilateral, that's right, equilateral triangle, because that's the way we work. It may not be the way you work, but you can think for yourself about how you do the chairs. And the way I do this demonstration is I just need 3 people who are able to, A, sit on a chair, and B, just repeat the words I ask you to say. So it's not about creativity at all. It's about repeating the words. It's not about showing that you know the right way to do it, because I want to demonstrate a wrong way of doing it so that we're getting into a muddle, okay? And if it, you know, and the person who's giving you the words to say is me. I'm the one who's getting into a muddle. So I just need 3 people as quickly as possible, because we've got very little time, just to come and sit on the chair. Yes, thank you. Okay, you can be the patient. I'm going to move slightly because the lights. Brilliant. You move the chair over. Fantastic. You're the doctor. Oh, hello. And you're the interpreter. We're going to do the whole thing in English because the.
I thought you said equilateral triangle.
It is supposed to be, but I'm moving it because there's a light that's kind of like shining in people's eyes. Move a bit closer. So the idea of this is not to demonstrate anything around language, because we're going to do it all in English, but just to demonstrate how quickly things can slip out of control. Thank you. Can you actually hear me without the mic? Yeah. Okay. All right. Okay. So can I ask you to just really speak loudly, just to repeat things I have to say? So we. Oh, okay, right. I've got this one here. It's on. Yeah, okay. Okay, so we're going to imagine that we're at the beginning of a session. Now, if you bear with me, I'm used to doing this in a mental health context, so you may very well not start your sessions with the sentence about confidentiality. But I'm going to ask the doctor here just to say that everything in this session is confidential, and I know there are lots and lots of caveats, but if we can just stick with that, just for the purpose of this, it will be very useful. So, you start off, you're going to say to the patient, I just want you to know that everything in this session is confidential.
Good morning. Thanks for coming in this morning.
Stop.
I thought you were giving me the bad.
No creativity.
Everything in this session will be totally confidential.
Okay, you repeat that, please.
Everything in this session will be totally confidential.
Okay. And you say to her, what do you think? Can I trust him?
Can I trust him?
Okay, so repeat again. What do you think? Can I trust him?
What do you think? Can I trust him?
Stop. Okay? Can you see the dilemma that the interpreter is in? Okay, the patient's asked a direct question to the interpreter. Okay, any thoughts about what needs to happen? Go on then.
Presumably the interpreter's got to convey that to the doctor.
Right, okay. So either the interpreter can convey it to the doctor, or the interpreter, another option would be the interpreter just reassuring the patient straight off, oh yes, 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 it's fine, he's fine, or no, he's terrible, get out now. So she could do that, but then, as I think you're rightly getting to, the doctor's going to be excluded from 2 exchanges, okay? So you want your interpreter to feed back to the doctor, yeah? Okay, so let's go from, what do you think, can I trust him?
What do you think? Can I trust him?
What do you think? Can I trust him?
And you say...
If he doesn't know the bloody answer to that question.
I think it's all going to go out of control. Okay. So what you say is...
Please reassure him that he can trust me totally. I am a doctor.
Okay, brilliant. But instead of speaking to the interpreter, I want you to directly speak to the patient, okay? Because that's another of the things I'm asking the clinician to talk to the patient all the time. So you're just going to say, of course you can trust me.
Of course you can trust me.
Okay, will you repeat that?
Of course you can trust me.
Say, what did you have to tell him that?
What do you have to tell him that for?
Okay, so can you see again the situation we're in where trust has broken down? She's done the right thing by telling the doctor, but he feels really let down. He thought it was just between the 2 of them. Okay, any thoughts from the floor, not here, from the floor, of what could have been done differently? Yes, shout.
At the beginning, to clarify the boundaries and how it was going to proceed.
Brilliant, give me the wording for the boundaries.
That it was a translation, a direct translation, that was her role to translate between the doctor and the patient.
Okay, get it better, that's good, let's get it better than that. Just the doctor and the patient? Okay.
Well, the other thing is actually possibly the doctor and the patient should be sitting opposite each other with the translator on one side and the whole interaction being with the person, with basically the translator just being, well, excuse me, but as a mechanism for translating, because then that makes the interaction a bit more powerful and personal.
Right, okay, so you can certainly think about how you do the seating, but in terms of setting down a ground rule, the ground rule that we say is to say, for the interpreter, for the clinician to say, everything that everybody says in the room will be interpreted. And the reason we do that is because if the doctor wants to make a comment, and it could be anything, it could even be just, oh, it's a bit hot in here, the patient won't know whether it's just a throwaway comment or whether it's something about his care. Okay? And so if you want to say anything that the patient doesn't hear, you have to do it when they're out of the room, not just because they can't understand you. And so we do that so that everybody knows those are the ground rules. So if he wants to say something rude about the doctor, he's been warned. He already knows it's going to go back. Okay? And that's about the power and the trust. The other thing I would say as well is often interpreters from other contexts are used to putting those ground rules down themselves with the patients. But I would suggest as a clinician, you take the lead. You do it because it's your way of being able to establish some control over the session. Don't just rely on the interpreter managing it all for you. Does that make sense? Okay, brilliant. Thank you very much. Okay, great. I haven't got time to do another role play, and I very appreciate the people who came up to do that one. But I also want you to think a bit again about the fact that if you're a clinician and you have to leave the room at any stage, it could be at the end of the session or it could be during the session, and you leave the interpreter and the patient on their own, what do you think is going to happen? They'll talk, but the patient will want to talk to the interpreter. And it's a very difficult position for the interpreter to be in, because that is when the patient may divulge something that is of a nature, for example, a child protection issue, that they haven't told the doctor, and the interpreter is left with it. And what do they do with it? Now, there are various things they can do, but but I would suggest just don't put them in that situation. So if you need to leave the room, they either leave with you, or you ask them to go and get the glass of water or whatever it is, and you think about how you're going to end the session so the interpreter and the patient don't go out together. And you think about how you're going to begin the session and how you have to think holistically about how your surgery works so that interpreters are not sat in the same waiting room as patients. Because otherwise they will start talking to each other. If you can't do that, it's fine. You just need to think about what the implications of not doing that may lead to. Okay? It is a bit complex to begin with, but it's a really, once you've got it into your system, it's very simple, it's very easy, and just everybody in the practice needs to understand that those are the rules and that's what you're working to, and then people work to it. Okay, so I've got a list of just tips. There are guidelines out there, but there are tips here. I'll leave that one, it's on the slides for you to see for yourself. There are tips. Don't read them all now. You can read them on the slides when you get at home. I just put them there so that you can see that they're ready. They are, some of them may be a bit more relevant to a mental health setting, but you can think about that for yourself. We have a pre-meeting and a post-meeting with the interpreter, just very, very briefly to brief them on what the session's going to be, and just to check at the end if there was anything that didn't go quite right. You may not be able to do that, but that's how we work. And we think about the beginnings and the endings. We have this ground rule about confidentiality and everything in the room translated. We ask interpreters not to keep coming up with really interesting information that may be culturally relevant unless we are really, really missing the point, but to tell us that at the end. Because even though they are from a particular culture, the same culture as a client, doesn't mean they have the monopoly on knowing culturally how that client interprets their culture and lives their life. Please, please, please speak in small chunks and stop the patient as well to get them to speak in small chunks, or the interpreter is never going to be able to manage. There are some more tips here, but I'm going to skip over them very quickly because you can read those for yourselves. And just now I'm going to think about what about the money, because, as I said, interpreters, paid professional interpreters are really, really important when you are working with complex situations. But I think if we become more confident ourselves as clinicians, we can work with a range of different language supporters. Research shows, and you can look at Alexander 2004 from the Joseph Rowntree Foundation, that patients overwhelmingly prefer to use family and friends. And I think that there are occasions when it is absolutely right to use family and friends, but I think as clinicians we can assess when those situations are appropriate and when they're not. I also think that volunteer language supporters, you're the wrong audience to be talking about this, but I need to talk to other people about creating pools of trained volunteer language supporters who can provide language support that's a really good quality at a certain level. And as I've already said, professional interpreters for complex work. And it is really important to distinguish cases where a professional interpreter should only be used. That's yourselves. That's you as clinicians making those decisions. And you can't know everything when a session begins, but you can take control and you can halt it. So if you've got a family member interpreting and you think this is going way beyond their competence, you can stop it and say, we'll have to have another appointment and I'll book an interpreter for it. But at least it goes some way to acknowledging the fact that people prefer family and friends, but that not always that can be accommodated. Okay. We could also have a kind of a matrix or a toolkit. There's an excellent toolkit for GPs that Dr. Gray in New Zealand, 2012, you can look it up on the web, GRAY, has developed a toolkit for assessing when to use different levels of interpreters. And if we work really, really creatively around language support, it will mean that there is the money available when we need to have professional interpreters, as opposed to having them used as a blanket for everything. That's it. Okay. Any questions?